Good morning and welcome to the ICE conference. My name is Brian Wilson. I know Jerry was in my CRES the past couple days, so I think so. Yeah, I guess I need to speak up. So what we're going to do today is it's kind of new for myself, and it's um, kind of a concept I've come up with. So I've been working in the Cath lab coming up on, I don't know, probably close to 20 years. I originally started working in the Cath lab area as a biomed. And I had a gentleman that worked with me, and he took care of the imaging part, which was all too fine with me because I had really no interest in working on the imaging stuff. But I guess in his wisdom, he still showed me a lot of things before I got into it. And so he decided to retire, and I got kind of voluntold that I was going to become the new Cath lab guy and take care of the imaging stuff as well. And so in my years doing that, it's been coming up on 15 years that I've been working on the imaging side of things. And one thing that I've noticed is that the disdain from my fellow imaging service engineers of working in the Cath lab. I mean, I was like brand new to imaging, and I'm taking care of the Cath labs, and our more seasoned imaging guy told me straight up, he said, you know what, I have no interest in whatsoever in doing anything in the Cath lab. And to my knowledge, the years I worked with him, he never did set foot in the Cath lab, even though I was like just brand new, fresh into the field. So I thought that was kind of odd, but over the past 15 or so years, I've also noticed that there's a large amount of people that work in the business that absolutely hate it. And it's not because they're not experienced. I mean, these guys have more experience or equal amount of experience and been working in it for years and decades. So I always wondered why people always had a disdain for the Cath lab in particular. So I thought, well, maybe it's just a case that people don't really understand it. Working as a biomed, I took care of a lot of critical care equipment. So I worked in the ORs and worked on like anesthesia and life support. So I really never had an issue with working on stuff that was hooked up to people and then like working in the OR. So I thought, well, perhaps it's just a matter of experience or exposure to working in an interventional kind of environment. So we'll go ahead and we'll kind of introduce, if you have any background in Cath lab, this is probably going to be a little bit of a review for you, but I did try and throw in some little nuggets in there that might be of interest to people that have been in it for a while. So basically, survival guide to the Cath lab, probably more appropriately named, probably be like Cath lab 101, but I'll give you some little tips on how to work around these guys and what goes on in them. So first thing we'll do is we'll go into the Cath lab. Now, Cath lab can look all kinds of different ways and definitions out there. Typically, there's two things that I've noticed that go on in the Cath lab and the type of procedures that they do there. Now, again, this could change from site to site, but this is kind of my experience overall during the years. So basically, what does a Cath lab do? So catheterization laboratory is the correct name for it. It was originally conceived in the 1950s as an experimental way to use flexible catheters and fluoroscopy to access parts of the body without using invasive surgical procedures. So before they did cath labs or interventional type settings, you basically had to crack the person open to access those parts of the body, which, open heart surgery is not a real pretty or fun thing to have to go through. So they were back in the 50s trying to figure out how could we get to parts of the body and even places that may even not be accessible through conventional surgery. How can we get in there? How can we see this? So they came up with the idea of using catheters and fluoroscopy as being kind of a way to let's see what we can do with this. So here's an early cath lab from back in the late 1950s. And so again, the primary source of the X-ray was fluoroscopy. And you can see them using a rather rudimentary video monitor to get their images from the X-ray system as they're doing their exam. Now, kind of hard to see in this. There's a camera up here as well, and it contains like a 35mm film in it, and we'll cover that here in a little bit. So they had a couple ways. So your live reference or your actual live image came across on the video screen, and then you had a backup camera that recorded the procedure as well. It's kind of hard to see. They have like your image intensifier, and then I would imagine that your tube's probably tucked down under here underneath the patient and the table. So the nice thing about fluoroscopy is with doing a vascular type study, you can actually see a real-time moving image of what's going on rather than a static like X-ray image that they would have had back then. You normally could view them on a video monitor. And later they found that they're both good for diagnostic and interventional type procedures. So here's an example of a catheter that they would have used. Well, actually, this is probably a more modern one, but just the idea. So it's basically a big flexible tube that allows them to go up. Back then, they would have probably accessed predominantly through your femoral artery. And now they, a lot of times will go through your wrist because it's less invasive and there's not as much trauma to the leg and the artery. And here's a cath lab from the 2000s that I started off taking care of. Angioplasty. So angioplasty is the type of procedure that they use, what I think of being kind of like the traditional cath lab. So patient comes in, they're having chest pains. They do some tests on them, do EKG, and do some lab draws. And then they say, you look like you're having a heart attack or a myocardial infarction. And so they call the cath lab up and say, hey, we got a patient here in the ER. They run you up and then they get ready to do an angioplasty on you. So what does exactly an angioplasty entail and where does it happen? So on the heart, most of us know about the 4 chambers of the heart. You have your left and right atrium, you have your left and right ventricles, and then you have your aorta then that goes out to the rest of the body. Well, on the outside of the heart and right after the very first part of the aorta as the blood's leaving out to go to the body is your coronary arteries. And your coronary arteries then feed the actual heart itself. So what happens over time, either through lifestyle or say lifestyle choices, smoking, drinking, eating the wrong food, not exercising, or even bad heredity, our coronary arteries start to get hard and they start getting to get clogged with all sorts of bad stuff. And so what will happen then is in time, your arteries will then quit working as well as they should have. And sometimes they actually get clogged. And what will happen then is then your heart starts saying, hey, you know what, I'm not getting the nourishment I need. I'm not getting the blood I need. And you'll at some point, hopefully not, but you may experience a heart attack. So here's an X-ray of what the cardiologist is seeing. So here's your different coronary arteries as they're going across the heart. You have one that goes across the right, and then you have one that goes kind of around, and then you got your 2 main ones that go down on the left side. Your left side of your heart's your predominant structure that pumps the blood, so it takes the majority of the the muscle and makes up the mass of the heart. So here's what an obstruction or a blockage looks like in the heart. So here's coming off your aorta, coming out to your various parts of your heart. So at this point, you're probably feeling something's wrong. And, hopefully you're in an area that you can get to a medical facility that has a cath lab. So this is what the cardiologist is going to see and say, yeah, we need to do some intervention here and get this opened back up. Now, unlike back in the day, if you had a heart attack, say like in the 70s, there really wasn't a whole lot they could do for you. They could give you some meds, give you some bed rest and some oxygen, and really just hope for the best. However, since then and now, in the event that you were to have something like this happen, you have a really good chance of returning back to a fairly normal lifestyle. Of course, with some diet changes and lifestyle changes, you'll probably be fine after having a heart attack these days. So here's what the catheter looks like actually inside the heart. You have these little markers that the X-ray is able to pick up, and uses kind of like a milestone for the cardiologist as he's inserting the catheter, so he kind of knows exactly where he's at in relation to the anatomy. So here's kind of just a basic diagram of what goes on. So here's your coronary artery. Here's, some, pizzas and cheeseburgers and other bad choices. Not to say that I'm a poster child of good choices, but as we, age, you'll get plaque to grow inside your arteries. So what the cardiologist will do then is they'll insert a catheter, and this is a balloon catheter, and so they'll find the blockage and they'll insert this balloon, and it will push the blockage kind of out of the way and restore the flow, blood flow back to your coronary arteries and to your muscles. And so here's a example. These catheters come in all kinds of different shapes, sizes, and styles. You'll hear the cardiologist, I need a 6 French J catheter, and the tech will run over and grab that catheter, and then they'll feed it through, and whatever they do with it past that point, I'm not sure, but I just hear the terminology when I'm in there working. So here's a little more, kind of detailed thing of what they do. So here's your narrowed artery, could be plaque, could be just as you age, your arteries do narrow and contract. So here's a balloon catheter with a stent on it. They'll introduce this into the coronary artery. The balloon will then inflate and open up the stent and push it into the walls of the artery. And then after they're done, then the balloon is deflated and then withdrawn, and then your stent will then kind of act as a bridge to hold that spot of the artery open. Eventually, in time, your artery walls will just grow within to the mesh of the stent, and it'll just be like another vessel, but it has that extra support, because with them opening up the artery, as well as with age and disease, the walls will be weakened. So this just acts as kind of like a support, keep everything open so that doesn't close back up later. So we'll go a little history lesson on some of the early cath lab technology and how it's developed into what it is. So this is a picture of a cath lab from what would probably be used in about like the 1960s up to the early 70s. And it really looks like just like an RNF room. The tube is down underneath the table, goes through the table, goes through the patient. And then like on an RF room, you might have like a spot film device or other recording device here, but in this case, it's just a platform for the image intensifier to sit on. So really for the first, I'll say maybe like 10, 15 years of cath labs. They were just basically a fancy R&F room. At least that's what it would look like to us this day and age. So the main thing that they used back in the day would have been the image intensifier. So this would have been the apex of analog cath lab technology up into the 1990s, 2000s. So you have your image intensifier, you have your cathode down here. Within side of here, you have your intensifying or your grids that then take the signal and amplify it up through the bell. And then in this case, you have your image gate in your camera here. And this particular system would have used a CCD camera, which we'll cover here in a bit. And now today, with anything, I just retired my last image intensifier room. It was an old biplane room. So it just went away a couple months ago. So now all my systems are digital with the digital detector. This particular one's kind of cool in that it can rotate the 90 degrees. So it can do kind of a lateral presentation, or it can do kind of a horizontal presentation like it's in right there. And so that way you can use it for, like in this case, this would be ideal for like a cardiac type thing. And if you were to rotate it and spread it out, you could then use it for more like interventional or peripheral type cases. So some of the old stuff that they used back in the day, and this would have been just coming up on the very, very beginning of my time getting into it. They had what they called cine film cameras and viewers. So if you've ever worked around the cath lab or have experience with it, you'll hear, the docs say about, oh, I'm going to do a cine run, or I want to review my cine run, or just look at your straight fluoro shots. So the term cine comes from actually cinema, which is the type of camera that they originally put on the side of the image intensifier to record the images. Now the doc would normally, as they're doing their case, would look at the image on a live video monitor, but after that particular moment was over, you needed a way to be able to record it. So they could go back and look and roadmap and see where they're at in regards to the anatomy and what they've done. So here's a really old cine film camera off of a image intensifier. So here you have, over here, you have your television camera, which was probably a pickup tube, which was an analog video camera. And so this is what would be recording the images off the II as they're using it real time. So as he or she are doing the procedure, they can then watch the heart and what's going on in the heart at real time with that. Now, off of here, you have an image gate, which then comes down here to a film camera, and inside of here would be like your traditional movie film. It was like a 35mm movie film that they used in Hollywood. Someone then adapted the camera so that they could record the output of the image intensifier and actually film it while they were doing the case. And we'll go over what the use of that was for. So here's an interesting shot. This is from, I believe, 1979, and I call it Cake in the Cath Lab. The two cardiologists are enjoying some cake in the cath lab. Must have been some kind of celebration. Either they got a new cath lab or someone retired or whatever. But some interesting points to point out this, and hopefully you can see it. So here, back behind right there is kind of their main viewing monitor, which would be like a big old giant, probably like 25-inch CRT. And then you have some of your side monitors up here. I don't know, you might have like your patient monitoring up there, or even have like a side monitor for like the staff working in the room so that they can see around the cardiologist and what they're doing. Now, right here, this kind of white oval thing is your cine film camera. And so this is coming off the image intensifier right there, right behind this guy's head. And this is what's recording the study or the procedure while they're doing it. Now this little gem here is called the cine film viewer. And this is where I come into the game. So we had a couple cardiologists, senior cardiologists, that insisted that we keep their old films and that they want to be able to review them. So I would get a call from the charge up in the cath lab and be like, Dr. Farrell wants to look at one of his old cine film images. And those films, at the very minimum, were 10 years old, if not even closer to 15 or 20. And I would point out to the charge, it's like, well, don't you think the patient's anatomy is going to change a little in like a couple decades? And he goes, I don't care what it takes, just get Dr. Farrell's film loaded up for him and help him with it. Because these things were notoriously cantankerous and always having problems. So again, like it's kind of hard to see in here, but there were like two spools, and you'd put the film on the one spool and then you hook it up to this. And then there's like a little foot pedal, and then the cardiologist could sit there and push on the foot pedal and then look at the film on the screen. And it was just kind of like watching a movie, but it was inside someone's heart. So as soon as those two cardiologists left, we promptly archived all their films, and this thing hit the dumpster as fast as we could make it. So I do have some experience with the old film, but they also had a special film processor, so they would pull the film out of the camera. One of the techs would run it through the film processor, and then they would load it up, and then the doc could review it right there in the room on the bedside. So then kind of to be able to look at and see where he's at in the patient's heart and kind of roadmap with it. Yes?
Isn't there a way just to digitize the old film and that way you have it, digitally instead of analog?
Yes and no, because back in the day when I was dealing with this, digital was fairly new. So we probably could have done it, but since those two cardiologists had been, were gone, we out of respect kept the patient's film and records, but we didn't invest in any, because like I said, it was probably 15, 20 years old. So really, someone came in their 40s and then they came back in their 60s because they were having chest pain again. There's probably a lot more dynamics going on than what this old film would have. But yeah, ideally it would have been, if we wanted to hang on to it and use it in a more modern fashion, digitizing it would have been the way to go. Now, one thing I was a little surprised, because doing my research on this, I saw the old RNF looking cath lab from the 70s, and I really didn't think that they had advanced that far. But by 1979, if you look here, it's actually a ceiling mounted C-arm. And so you can see the gantry up here, and the gantry will come out and then, line up with the table. And, it's a traditional C like you would see in the cath labs we have now. So I thought that was actually pretty good. Of course, in 79, I was in junior high, so I didn't know anything about cath labs and I'm quite honest, I don't know if we even had any in town at those days. Cath labs were still fairly uncommon. So actually, I was really surprised though to see a ceiling mounted C-arm arrangement as early as 1979. So one of the things from those of you that may have been in radiology for a while and have had to work on, say, like an old Advantix system, is the old pickup tubes. So from the very early days, they would have been using a pickup tube as their video source off the image intensifier. And so basically all a pickup tube is an old analog video camera that they would have used for, like, say, making TV shows or maybe even movies. So it's kind of unique that they were able to adapt that technology as well as the movie film technology for use in the medical field. So that, like I said, the very early cath labs would have used a pickup tube and as their source for the video signal. Now, again, the apex of the technology would have been a CCD camera, which stands for charge coupled device. It's basically a solid state camera that, again, sits off to the side of the image gate that's on the top of the image intensifier. And it does the same thing. It makes a video image of the what's coming out of the image intensifier. And what's nice about these is they're solid state, so they don't use as much power and they're a lot more stable than the old video cameras. But unfortunately, and the old timers will point it out, they don't make as nice of a picture. And so they kind of did, and it was kind of a disservice to them that when they took away their pickup tubes, their video cameras, actually their image quality went down. Fortunately, though, that's changed. But yeah, if you talk to an old-time cardiologist, they'll remember their machine from 15, 20 years ago and say, man, I could get a lot better image from it then than I can with this technology. And then, of course, now we have digital detectors. So here's your digital detector. This is your X-ray tube, and then you have your traditional C. Now, this is a floor-mounted model as opposed to the ceiling-mounted we saw in that 1979 photo. So basically, for those that aren't aware, so the X-ray comes up through the table, through the patient, and then makes its image on the digital detector. It then sends its information back to an image computer that puts it all together and then puts it up on a flat screen monitor, in this case, for the cardiologist to review as they're doing the case. Now, one of the benefit of this is we don't have to use the old cine cameras that you don't have to wait for the film to get developed and have someone load it up and spool it for you and review it. You can then have, through the computer and the software, bring up your runs, as they call them, cine runs, and then you can either have someone do it for you or you can do it from the table side. There's like a little controller that will allow you to go back and review your previous images. And then that gives the cardiologist almost like real-time instant information as to what's going on and what they've already done. So here's a digital detector in a less than ideal state. So like I showed you the main part of the pizza box. So if anyone's wondered, this is what the back end of it looks like. Now this is a fairly older digital technology, probably maybe almost like first generation. So it's quite a bit bigger and bulkier than a lot of the digital detectors you've got now. But considering the environment that it's used in and how much radiation it's getting hit with, I don't think you would want probably something that's less robust, because these things are constantly getting pounded with radiation, and they have their own built-in cooling system as well to help keep them cool while they're getting subjected to all that radiation. So even though it's kind of old and clunky looking, it's probably ideal in order for it to survive in the environment that it's being used in. X-ray tube. So one of the things that differentiates a cath lab or an interventional lab and its X-ray tube versus, say, like a traditional X-ray environment is in order to make the pictures, and this goes clear back to the original old cine cameras, is that the output of the X-ray tube is pulsed. So within a cath lab, you can select a frame rate, a lot like an RNF room, you can select different frame rates on them. But particularly with the cath lab, you can select like a 15 or 30 frames per second speed. Well, in order for this to work, you have to have a special tube that will allow you to do pulsed fluoro. Now, back in the old days, like that first picture I showed you, the fluoro ran continuously, so there was no pulsing to it. So the patient got a lot of radiation, and the camera, it kind of had a flickering effect to it because it wasn't synced with the x-ray. So some of the images would come out well and other of the images were kind of not so great. So here's a Cath lab x-ray tube. So right here is your collimator. And then down here is this would be an MX150, those of you that are familiar with GE. Now, this guy right here is called your Ingrid, and it plugs straight into your cathode port on your X-ray tube, and then your high voltage cable then plugs into the Ingrid. So what the Ingrid does is it matches the speed of the detector or the II, depending on what your setup is, and it pulses at the frame rate that you tell the that you want to record at. So this would pulse at 15 frames per second or 30 frames per second or whatever speed that they've selected. So both the tube and the detector or the II would then be in sync with each other so that you get a nice clean image as it goes across. And what's also a benefit is that it doesn't expose the patient to as much radiation as you would if you just let it like go on straight fluoro. Then here's the tube itself out in the open. Pretty heavy duty tube. Right here would be your cathode port for where your high voltage would come through, and then your Ingrid would sit here on the side and then pulse the signal to the X-ray tube so that it's in sync with the detector or the II or whatever camera you're using on it. Broken cath lab, the bane of every service engineer's existence. So this one was really bizarre. It's basically all the peripherals quit working on it. So the table wouldn't go up and down, it wouldn't pan, it wouldn't move, the detector quit working. I think the C-arm had very, very limited options. It would like kind of sort of move, but I mean, basically it was broken all the way around, as well as the little part, then that's why the detector was open, is the mechanism here that would move the detector up and down for its SID. All of that was, and so it was kind of a complex problem. Coming to find out it was corrupt software. So we're looking for some magic, silver bullet that some mechanical or electronic piece went out on it. And we're chasing our tails on this thing for days, and come to find out it was corrupt software that just took out the positioner part of the program. So
redo the entire hard drive, or just
at that point, yeah, we just called GE in and said it's yours, and then they came back and said, yeah, the software was corrupt on the positioner. So I didn't know if it was the local software in the positioner cabinet, or if it, like you said, you had to reload the whole application host software. But yeah, so you don't want to. This was a bad day. So just for those of you that may not have seen the inner workings of what one of these looks like, kind of give you a behind the scenes look of what a broken one looks like. Now, within this past year or so, we've had to deal with COVID, and I felt pretty safe with the fact that I work in the cath lab. Why would I worry about COVID? Because we have cardiac patients coming in. We don't have COVID patients coming in. Well, come to find out, COVID messes with people's hearts. And we had a lot of people coming down to the cath lab that were infected with COVID. And unfortunately, this picture doesn't do the room justice. You can kind of see here in the back, basically everything was draped. So other than the actual table itself and the C and the anesthesia cart, everything was covered with these biohazard drapes. And for myself, this, right after I took this picture, or shortly thereafter, they were having some issues with it. I'm in here with no biohazard protection. Why would I be wearing PPE? I'm working in the cath lab. I mean, I'll wear gloves because it's kind of gross, some of the spots on the floor and around the table. But other than that, I'm going in my mind thinking like, well, I'm in a safe zone. I don't have to worry about this stuff. Well, I'm working on this thing and they roll in a COVID patient and everyone's in their PPE gear except for me. So it was just kind of a unique thing to think that how far the disease reached in areas that you really wouldn't anticipate seeing a COVID patient. But I guess they do have a lot of patients that have complications from COVID that affect their heart. And of course, the first place they're going to go to is the cath lab to get it checked. This room itself too is kind of funny. And I did talk to the director of labor and delivery on this story, so there is some truth to it. So the story was we had a rather significant snowstorm. I'm from Denver, and so a couple times a year we'll have a good old blizzard come through town and we'll shut things down for a while. So the story was that the woman that was pregnant came into the ER and they didn't have a OBGYN. They couldn't make it in. All they had was ER doctors and a cardiologist available at the time. So the truth of the story being is the cardiologist did take care of the woman that was pregnant. The wrong part of the story was they didn't take the pregnant woman to the cath lab, as a part of the rumor went around that they said that they took her to cath lab 4, which is this particular one. And that for me is where I had to get the director of L&D involved and find out for sure really what happened. So no, it was true that the cardiologist did take care of the woman. Fortunately, I think it was the police were able to go out and get the OBGYN and bring them into the hospital in time to deliver the baby. So I made a joke to the L&D director as well as the director of the cath lab. I said, well, you know, if we're going to have cardiologists taking care of doing deliveries, that maybe we need to put some stirrups on the side of the cath lab table. Well, the cath lab director thought that was hilarious, and the OB or the L&D director just snarled at me and got up and walked away. So a little cute story about this particular room. But yeah, there was truth. The cardiologist was taking care of the pregnant woman. Fortunately, the OBGYN made it in and they were able to deliver it in the L&D suites, not in the cath lab. So again, a little humor to go along with this particular room. Injectors. Well, I don't know about for you guys and gals about your feelings towards working on injectors, but I absolutely hate them. I mean, to me, it's just basically it's a big syringe pump. But as part of working around the cath lab, here's a Medrad or Bayer Mark 7. Injectors are kind of the bane of our existence. They're really not that hard to work on, but again, it's just kind of one of those deals. It's like, no, I fix the X-ray stuff. I don't work on the injectors. But interesting story on the injectors and how they got to be used in the cath lab and interventional areas. Back in the late 50s, on that one picture I showed you, I believe it was the Cleveland Clinic. They'd been messing around with using injectable dye to kind of enhance the visual or image quality of the exams that they were trying to do. But there was always a conventional wisdom or fear that if they put too much contrast or dye within the heart, that it could potentially stop it and kill the patient. Well, that would be a bad outcome for something you're trying to do with it. So the story goes as they were doing a procedure and the assistant to the physician or cardiologist was in there helping, and the cardiologist said, well, let's push some dye and see what we see. Well, the assistant pushed the full amount that was in the syringe. And when the cardiologist realized what happened, he was like, oh no, we just killed this patient. Their heart's gonna stop and we're over, game over. Well, come to find out, kind of like a Bob Ross happy accident, it worked. And they were able to do really good images of the coronary arteries, and the patient's heart didn't stop. So by accident, they were actually able to invent the idea of doing angioplasty and doing what we all it's quite common and familiar as far as what they do in the cath lab. So fortunately for millions of people, it was a happy accident that they discovered that you could use contrast dye within the actual coronary arteries of the heart. So that's why an injector is such an important part of the whole equation. Really, if you don't have an injector in the room, then really you don't have the cath lab available either. Now they can hand inject, and if they have to do that, you will hear from the techs continuously on their protest of having to do it, but it can be done. But of course, with the injector, makes life much easier for them. The other part, and it's probably the most misunderstood part of what goes on in the cath lab. So depending on where you're at, there's a combination, all kinds of combinations of what they can make up or justify a cath lab. So for myself and for you working on this type of stuff, there's no difference on the machine. The only difference on the machine you might find is your digital detector might be bigger or smaller. The table might have more features. Some have like the ability to do subtraction, some don't. Some can tilt, some can't. But really, other than just some minor technical differences, they're all the same machine. So when we work on them, there's virtually no difference other than maybe there's some more junk on the other ones. So the EP lab, and at least the ones that I work on, they have like a couple, 2 or 3 dedicated to doing the angioplasty, which I call the plumbing side of the business. So they're in there, they're doing roto-rooters, they're opening up people's coronary arteries. Now the EP lab's kind of a specialized deal. Now from our perspective, it doesn't matter whether it's an EP lab or a cath lab because the x-ray is the same. But within the EP lab, there's a difference in the equipment, which I learned how to work on when I was biomed before I took over doing the imaging. So we'll go over it since they kind of go hand in hand with each other. So basically EP stands for electrophysiology. And so within the parameters of the heart, you have basically the 2 sides. So you have your coronary artery side, the plumbing side that keeps the blood flowing and everything working there. And then you have the electrical side. And so on the electrical side, you have 2 nodes. You have your SA node and your AV node. And what basically that does is it regulates the how the heart works. So I use, for example, when I take the biomeds up to the cath lab to kind of introduce them and let them know what's going on. Basically, these 2 guys help you helps your brain tell your heart what it needs to do and in what kind of urgency. So I said, if you're sitting at home and you're watching a football game and drinking a beer, your brain's telling your SA node like, hey, we're chilled, everything's cool, don't worry about a thing. Or if you're out camping and in the woods and a bear comes out from behind a tree, your brain tells your SA node, then later your AV node, hey, there's a bear in front of us, we need to do something. And so it's kind of its way of telling the heart, okay, get ready to run, or we need to do something. Well, unfortunately, either through age or through a lot of times heredity, this stuff doesn't work the way we want it to work. And so what either you have people that it's too active and too busy, or it doesn't respond in a timely manner like you'd want it to. Another part of the between the SA and AV node is you have your Purkinje fibers, and then you have your bundle of His that take the electrical signals and then run them around the heart. And basically, it's part of your nervous system to let your heart know what it needs to do at any particular time. So your SA node is kind of like your commander-in-chief in that it tells the heart what it needs to do. So it's the natural pacemaker of the heart and initiates the electrical pathways for your normal, like your EKG that you see. And so what this does then is kind of synchronizes the heart so that it tells the atrium when to push, and then it tells the ventricles when to push, so that they're not working against each other. So some of the arrhythmias will cause people to not have that nice synchronized movement within the heart. The AV node is anterioventricular node, and it's more responsible for kind of regulating the rate of your ventricles. So the SA node tells the atrium to do their thing, and then sends signal down to the AV node and says, okay, get ready to do your thing. And then between the two of them, that's how they have a normal heartbeat. And so, like I said, in the other one, we had the AV node sends the impulse down through to the ventricles through the bundle of His. Your bundle of His is on, you'll hear like your left bundle, right bundle, if you're working around the EP lab. And then they break out into the Purkinje fibers, which are running down below your ventricles, and then causes your ventricles to contract and then push the blood out. So some of the things that they will have people come into the EP lab for are arrhythmias. And some of the symptoms from those arrhythmias due to abnormal electrical activity within the heart include low cardiac output. So if the heart's out of sync, it won't be as efficient as it can be. You can have syncope, which is fainting, and then also sudden cardiac death, which we all don't want to see that happen. One of the procedures that they'll do in there is, it's kind of almost like a surgical type procedure, is they will do an ablation. And what the ablation does is it destroys that part of the heart that is having the bad electrical signals. Now, before they get to this, a lot of times they'll try and use like medicine, like beta blockers, to try and regulate maybe your arrhythmia. Say like you have atrial fib. They will then use that to kind of maybe slow down the heart and regulate it via medicine. But for some people, that doesn't work, or it's too severe that the medicines can't regulate it. So that's a trip to the EP lab. Now, one of the things they'll do after the ablation on a lot of patients, they will put in a external pacemaker. So this will replace the part of the node that they might do the ablation. So if they might ablate the SA node, or they might ablate the AV node, or in some cases they might do both if it's bad enough. So you'll have either a single chamber pacemaker, or you'll have a dual chamber pacemaker. So if you have a single, you're controlling one side or the other. And if you have a dual, then it controls everything. So the pacemaker is basically running the whole show on that scenario. Most of the ones you'll see come into the EP lab are your SA node people. So it's the primary pacemaker that's gone out. But every once in a while, you'll see people with their AV node get a pacemaker put there in maybe their SA node's fine, but your ventricles aren't working like they're supposed to. Another kind of device that you'll see implanted in the EP lab is ICDs, which are implantable defibrillators. And so there will be people out there that will, for whatever reason, they may have a normal sinus rhythm, their heart works fine 99% of the time, but they may just all of a sudden just drop. I mean, for no reason, their heart will stop beating, and you know, could have that sudden cardiac death episode go on. So what these guys do is that they'll you know, monitor the heart, and if the heart were to go into some kind of arrhythmia or stop beating, then this guy will jump in and jumpstart the heart and get it going. I really have to feel for these kind of people, because you don't know when that moment's going to happen, because otherwise, for a lot of these people, their heart works fine otherwise. So fortunately, they do have this technology to help people like that. but this is another type of device that you might see being implanted in the EP lab in a case. Hybrid OR. So when I first got into the business, we just really had just the cath lab. We had the coronary or the angioplasty side, and then we had the EP side, and seemed to work for the time. I didn't see it being an issue. However, when we first started doing TAVRs in the cath lab was when I started seeing kind of the problems creeping in. For one, the cath labs really aren't designed to use anesthesia in them. And I have an anesthesia background, so that worked to their favor as I was able to MacGyver one of the cath labs to be able to use anesthesia. Well, even back then I pointed out to them that this really isn't an ideal scenario because you don't have the proper ventilation to work with anesthesia. I said you can have a bunch of sleepy cardiologists and techs in here if we don't properly vent it. The other problem with doing that type of procedure, the more invasive procedures, was the sterility. The cath lab wasn't designed, it's a clean environment, but it's far from sterile. And you know, when you start getting into patients' bodies and doing work with that, really the cath lab is not an ideal location to do those type of procedures. So over the years, they've come up with this idea of doing a hybrid OR, and we'll go ahead and cover some of its. So here's a hybrid OR. So it's in a specifically in an operating room. It's not like some cath lab room like I did with that one room to kind of MacGyver it to work. It literally has everything you need. So one of the attributes is you have the proper flow. So you'll have flow coming in the room, and then you'll have like the return flow coming out of the room. And that creates a nice flow of air in the room, both for the sterility and for the anesthesia, because in case the anesthesia were to have an issue or a leak, you don't want that all going out in the room and taking everyone out in the middle of the procedure. So the room is actually set up as far as the airflow in the room to handle the anesthesia and also to keep a nice pressure in there to keep any foreign like pathogens or other contaminants that might come in there. Now this particular room is kind of unique. It's a Siemens Artis Zigo. And what they basically did is they took a traditional cath lab C-arm and they mounted it to an industrial robot. And unfortunately, I wish I would have taken some video or better pictures of this, but this thing was incredible. The arm on this could actually reach probably from where I'm standing almost to the door leading out of the room. I mean, it could stretch that far out, and it could pick itself up, and it could do like a lateral view over the top of the patient and over the table. And it could also do a almost 360-degree rotation around the whole table. It was the back end that kind of got hung up, but hadn't there not been other things in the way, it could almost do a 360 around the whole patient and around the whole table. So the robot did all kinds of incredible things. Unfortunately, in hybrid OR, they don't do much in the way of movement, so it was way too much technology for what they ever used. But as a tech, it was really fun to go in there and play with it and see all the different things they could do with it. This particular one of the rad techs came in and played with it and actually literally got it stuck up against the ceiling. And that was rather unique to try and get that back down, because the little cable up here, there's a cable reel, couldn't retract in order to let the C back down. So I had to climb up on the back of this thing and kind of ride it like a horse and pull in the cable reel so that the C arm had enough room and slack to back off the ceiling. How they did it, I don't know, and I'm glad they never did it again, but that was a unique situation to deal with. TAVR. So one of the procedures that they've moved into the hybrid OR is a TAVR, and it stands for transcatheter aortic valve replacement. So pretty slick. Like I said, I was at the hospital that I first learned how to work on cath labs. We did our first TAVR in the cath lab, and with a bunch of different people, we were able to kind of MacGyver a room to be able to do these. And so basically what a TAVR is basically you're replacing your aortic valve with an artificial valve. They go up through the aorta, and they come in and they rotor-rooter the old aortic valve out of the way, and then they drop the artificial one in place and then implant it right on the output of your left ventricle. So really slick system. So that way then people that might have a heart murmur or some other like leakage out of their aortic valve, they can do this all through the femoral artery and up into the aorta and into the left ventricle. Really slick system, and keeps people from having to get an open heart procedure where they'd have to crack them open and then do this surgically. So on that one robot system and that thing, I had to laugh because this is my hand, and this is the robotic knuckle that made it do all the crazy things that that room could do. Now this little label up here warns you that there's a pinch point. Well, if that's the pinch point and that's my hand, that'd be pretty much the end of my hand if that thing got caught in, if my hand got caught into that. So I'm glad Siemens at least notified people that there was a potential pinch point, but I would think it might warrant a little more notice than just a little label there. Another thing that they'll do in the hybrid OR is AAAs, and it would basically stands for abdominal aortic aneurysm. And fortunately, due to the the availability of the technology, AAAs aren't the death event that they used to be. I remember getting in back decades ago into a hospital, you would hear someone coming in from the outside with a AAA, and you would just gasp, because that pretty much meant that if they didn't get him in time into like the CVOR and crack them open and fix that, they were dead man. That was pretty much a year goner. And I would saw the majority of the people that came in with AAAs didn't make it. Well, thanks to technology and awareness of this, AAAs aren't the scary thing that they used to be. So basically what a AAA is it's an aneurysm down here. Your aorta is a really long vessel, and it'll go clear down into your abdomen before it splits off into your renal and your femoral arteries. And so basically it's an aneurysm that, you're, like I said, with age, I guess particularly with smoking in males over 50, there's a risk of your aorta, your abdominal aorta, starting to kind of pooch out and lose its ability to hold itself together. So through screening and through high risk factor identification, they're able to catch these guys doing like an ultrasound scan and, get you into the, in this case, hybrid OR, and get that fixed. So the type of procedure they use is called an endovascular aneurysm repair, or an EVAR. And so basically what they do, just like the heart with the coronary arteries, they'll introduce a catheter through the femoral artery and then run it up to where the AAA is. And then they will then deploy a stent. And these stents are huge. They have examples of them in the hybrid OR that I work in. So a coronary stent, I mean, they're tiny. I mean, you could probably put them on the end of a like a ballpoint pen, and even the ballpoint pen would look big. But these guys that they use for the AAAs are about yay big, and they're about as big as, probably bigger than a quarter, maybe even a 50-cent piece. They're huge. And you would never think that, how can you introduce something like that? Of course, they're all smashed up around the balloon catheter that they used to introduce them. But yeah, I had no idea that the aorta was that big of a vessel. So I could see why when people came in with AAAs, especially if they had ruptured, I mean, that much blood gushing out of a vessel would have been catastrophic. So even though the picture doesn't really do the stent justice, the stents for these guys are really substantial. So if you're ever in around a hybrid OR or like a vascular lab, that's what they do. Just look around and see if they got a stent, because I know they like to bring the students up there and show them, now this is a real stent, not the little guys that they use up in the Cath lab. And again, here's the backside of my robotic monster. Kind of give you a idea. Here's an infusion pump right here. And then here's the size of the robot. Now the robot almost goes clear to the ceiling. And like I said, I could take this and extend it clear out outside the doors here, out into the OR. And, you know, just kind of for fun and games, you know, torment people that, you know, they had their Da Vinci robot, and I had my Frankenstein robot here. But no, it's pretty cool. And this system too also had a rotating detector and a rotating collimator. And when the guy that installed the room was doing his calibrations, he said, here, check this out. So he put an apple here on the end of the table and had it do its spin. And it did a complete 3D spin of the apple. And just like a CT scanner, you could flip it all different directions you want it. You could slice it, put it back together, reconstruct parts of the apple. You could see the core, you could see the seeds in it, you could see the stem. I mean, it was amazing that from basically a C-arm, you could get that. Of course, the computer hooked up to it was amazing as well to be able to do that. But this could actually do 3D imaging as well as do like CT slices and flip and slice the apple into whatever type of view you want to look at it for. And I like to always, you know, point out, of course, radiation safety. You know, you got your time, less time around it, the better. Distance, keep away from the source or the X-ray beam. And then always, if it's possible, either wear lead or be behind some kind of shielding. And thank you for your time. And I guess now, if you want, we can open it up to questions or comments or any. Yes?
With your CT spin capabilities on the system, do you find the radiology trying to get into the room as well to do any of their work, like kyphoplasties or anything like that, or is it a dedicated cardiac?
It's a dedicated cardiac. Now, when I say it can do this, it can do it, but compared to a CT scanner, this thing's like really, really slow. So it took, I want to say at least probably an hour to do the acquisition of just the apple. So it does have some pretty cool capabilities, but it takes really long time. The computer on it's amazing, but it's nothing like what a CT would have. Now, like they do have neuro labs now that they're biplanes, and the computers on them are again amazing. And they're able to do like a 3D spin of the head and of all the arteries and vessels inside the brain. And it's fairly instant. I wouldn't say it's as fast as a CT, but for what they're doing, they move pretty slow going through someone's head. So they're able to do some really good 3D construction with this type of a, you know,
Coil placement.
Yeah, for coils and stents and stuff up in the brain for like strokes and aneurysms. So this technology can work, but compared to like the radiology would be, I don't know, out of there in a heartbeat because how slow it is compared to what they've got.
There's other labs like the angio labs or special procedure room. What's different about those labs?
Well, and I'm glad you point that out, because I originally put this in my slide. I put in the vascular labs, I put in the neuro labs and some of the specialty stuff, interventional radiology. But I didn't want to deviate too far from the cardiac topic because then you could go through all kinds of rabbit holes and different things. But yeah, so basically in terms of the machine themselves, the C-arm and what they use, there's really virtually no difference because they use the same rooms or same machine in IR as they do in the cath lab and in the angio rooms and vascular rooms and stuff. I think it's really a difference as to how they want to arrange it. And for one, you have a power struggle between the cardiologist and the radiologist. So I think the conventional wisdom is just to separate them out. And, but yeah, like if you were to go into an interventional lab, these pictures I showed you I mean, there would be virtually no difference. You could use that robot room for interventional or a vascular application. One thing I have noticed in the past handful of years is that the dedicated vascular rooms are now being put into the hybrid rooms, that they can basically do the same thing without having separate disciplines. And so they can do their peripheral cases and other stuff like that. Other places I've been, like the cath labs, especially like the peripheral artery disease that they do in a vascular room, the cardiologist jumped on that for a revenue stream. And so they're always fighting with the vascular guys saying, you know, like the vascular surgeons, well, no, we can do peripherals in our cath lab. So I think it just depends on the politics and where you're at. The other thing I forgot to point out on the hybrid OR that's an advantage is with it being in an operating arena, you can, a lot of them, like the newest one that they put in the hospital I work at now, has the ability to do open heart. So if you're in there doing a TAVR or say a AAA or some kind of, you know, like real invasive procedure and something goes wrong or you can't fix it doing it intravascularly, then they can bring in the perfusion machine, the anesthesia machine, everything's just ready to go. And then they can open up the patient and do a traditional invasive OR procedure. So that's another advantage of the hybrid OR is that if the vascular type procedure fails, then they can go full blown and they don't have to have the patient come back, or if there's an emergency, everything's just right there and ready to go. So that's kind of the advantage of hybrid.
Do you have a large interventional cardiology group associated with your?
Yes, we do. We do. Ours is like kind of a neurotrauma center. So we get a lot of neurotrauma come in the interventional department. I think we have 5 labs and 3 of those are biplanes. And 2 of them are just kind of like your traditional interventional radiology type scenarios. And then the other 3 are all dedicated neuro rooms that they do a lot of stuff in them. So yeah, we do have actually it's probably as big, if not bigger than the cardiac side. But
both cardiac and interventional. Do you ever get into a situation where one of the physicians like to see the image quality a certain way and you set it up and then somebody else doesn't like it? And you ever get into those situations?
I used to. Back when I got into it, the docs, particularly the older ones, would complain about the image quality. And we had to laugh because a lot of the times it was not the image quality of the machine, it was the image quality of their eyeballs. Because we'd laugh, we had a couple of our older cardiologists and they'd be literally leaning over the patient and you'd have one of those large format monitors and their face is like this to the monitor and you're going like, doc, really, you need to go see the eye doctor or, you know, call it good. With the new machines, there's really no way to change the image quality. It's all controlled by software. It was explained to me by a service engineer how they go through all that process, which was way above my pay grade. So I just, you know, just smile at the doc and said, sure, I'll see what I can do. And there's nothing I can do. I mean, it's all built into the system. So there's no tweaking or I mean, if there's an image quality issue with, say, like, I don't know, maybe like the collimator's got something sticking in it, or maybe the x-ray tube's going out and it's not penetrating like it's used to, of course, those image quality things we can deal with. But as far as what picture comes out on the screen, there's virtually nothing we can do anymore to tweak it like we used to.
In what applications are used by playing on what application the CR that you show us?
I'm sorry.
Single plane versus a biplane?
Single plane.
Single plane to one CR.
But they are digital or
Yeah.
detectors or?
Yeah, so everything that I've got now is a digital, like a digital detector. I just retired my last biplane with the image intensifiers on it. So yeah, everything's digital now, so it's recorded as a digital image and then sent over as a digital image, so there's no conversion factor anymore. And then, yeah, no, I don't have anything else that, you know, that uses anything but a digital detector. And even that old biplane, they used only when they couldn't get into their digital biplane rooms. So the radiologist that got stuck with that room was really, really upset. So I hope that answered your question. Sure.
What procedures do require biplane versus single plane?
So I see like two things that they like to use the biplanes for. One is they use the biplane for the neuro stuff. So like I was explaining, we have the 5 interventional rooms and the 3 biplane rooms are almost exclusively for neuro. And that gives them a much better, and I think also for the 3D reconstruction, helps them be able to see in the head so they can get a lateral shot as well as an AP view of where they're at. And I'll admit there's a lot that goes on in those rooms that I'm really not that astute to understand. I have one neurologist, he'll take the time and he'll explain some of the stuff for me, but some of it's just like, wow. I mean, you guys, you walk with the angels with where your guys are in there doing and some of the procedures. Now, like I also see, we have a pediatric Cath lab, and they like to use the biplane for that. And I think it's more for reduced radiation because the tube and the detectors are smaller on the biplanes, or at least the one that we have. So I think they like to run the little guys in there and use the biplane. And I don't know if they use it as a biplane, but I think just because the size of everything, and then it allows them to get in a little tighter angles than they would with a traditional, like, you know, like C-arm set up like a single plane. Those are the 2 areas that I see biplanes used in. I'm sure they have other things that they can use them for, but those are only the 2 areas that I'm, you know, acutely aware of. Well,
Use also the portable CR as well in the labs?
When I first got started on it, like, and we're talking almost, well, 15 years ago, our EP lab was a portable C-arm, and it had a radiolucent table in it. And with EP, you really don't use X-ray a lot. You're just taking shots of the heart and where you're placing your leads in for like the pacemaker and stuff. So we did use a C-arm, but again, this has been like 15 years ago. So I haven't seen that used in a long, long time. They do make a vascular C-arm that can do like cine. And so you can do real lifetime images. And some of the new ones, like the digital ones, the detectors are obscene on them. They're like, would be like the equivalent of, you know, I'm using an II as an example, like a 12-inch II, which would be bigger than a lot of the cath labs I worked on. So yes, if you were in a situation where your hospital may not be big enough to have a dedicated cath lab or interventional lab, you could use a C-arm in like a surgical table to do it. I've had cases where they've had an emergency case where they've brought someone in and all the cath labs are full, and they had still that old EP procedure room, and we'd fire it up and they would do an emergency cath in there. But that was only in really extreme rare cases that they would go there. But I suppose it depends on the situation that you might what your facility might be able to do.
OEC is actually partnered with somebody. We got a new cardiologist, and I'm in a 2 hospital system. And they just bought him 2 brand new OEC Elites with, flat panels and everything. But each one at each site came with, the C-arm, but also a video monitor, a 55-inch.
Oh, wow.
Yeah, so basically making a cath lab in the OR, and also a specialized table.
Uh-huh.
So and it came straight from OEC as a package.
Wow. No, like I said, it's obscene because I saw what these new Elites, the size of the detectors on them. I'm like going, that's bigger than I've got in the cath lab. And, I guess for some of the procedures, I mean, it's great to have the big field of view if you need it. But, here you have a portable C-arm versus a, dedicated room with a floor mounted or ceiling mounted, So I don't know, maybe that might be the trend for the future is to be less dedicated and more flexible.
It's pretty nice setup because, the video card on the newer Elite model, it's no slouch. It's a nice big screen. And then it gets plugged into our integration. So then you've got the monitors in the room, and then you have that big 55-inch sitting there, and everything's completely configured.
Yeah.
It's a nice setup. It rivals most cath labs that I've seen.
It sounds like it, and that may be the trend. The only thing that I can see that would be a drawback to doing it that way is, of course, C-arm doesn't have the image processing that a cath lab does, because you have a dedicated computer that's all it does is it just cranks on those images and puts them together and both processes them and stores them, and if you got something that's cranking out 15, 30 frames per second, you need a pretty good acquisition computer to keep up with that. So I could see for say maybe like a TAVR or like an EP procedure, that OEC Elite system would be ideal because you're really not doing a lot of X-ray. But say for a straight up cath procedure, I mean, those guys are just hammering that, exposure pedal and making all kinds of I think some of the runs can be up to, well, combined cases, you're talking over 6,000 images. And I don't think there's too many OEC systems out there that could crank out, but the way the memory is and how computering is, they may have a solution for that. I don't know.
Well, we've got cath labs also, so
I
was kind of confused.
No, but for say if you were in a outlying hospital or a rural hospital and you didn't have the money or the resources to dedicate to a full-blown cath lab or IR, something like that would be way better to do than sending someone off to the big city and waiting that time. At least you could get in there and do some kind of intervention and then send them off in better shape than if you were to, fly them out or drive them out to a big hospital. So no, that's good to know. I was not aware that OEC had that available, but no, I have seen their new flat panel detectors, and I just shake my head and goes wow, that's better than what I got on a lot of my machines. So no, well, I'll have to keep that in the back of my mind and see if that's a trend with the hospitals and them moving that way.
Probably all it has to happen is the cardiologist asks for it.
Yeah, if they want it, they get it.
That's what we're driving.
Yeah, I mean, if they can make money with it, they'll find a way to use it. Well, thank you for your time, and I appreciate you coming out, and hopefully I shared some knowledge, and I wasn't too involved in the clinical side of it. I think it makes sense to throw clinical in there to understand what they do and why they do it, aside from the fact that they constantly break our machines.
Thank you.
Oh, you're welcome. Thank you.